Okay, I'd like to welcome you to EMS Trauma Grand Rounds. Today, we're honored to have Judy Sampson, one of our nurse practitioners for the trauma service. We didn't want to go into how many years she's practiced, but she's practiced here for at least 5 years as one of our nurse practitioners. I knew her from LDS Hospital and in Salt Lake City. And she's going to talk to us about mechanisms of injury, and she's got a great slide presentation prepared for us.
It's adequate. How's that? It's an adequate slide presentation. Good morning, everyone. So when Russ kind of approached me about trauma ground rounds, and he gave me some suggestions, and so we thought, pardon? Like that? How am I doing?
Yeah, you're doing okay.
So we thought mechanism of injury would be a great presentation. I have to figure out the computer. It was working. There we go. So anyway, this is kind of the reaction I had. This is my grandson, and when I went home and told him, he had the same thought I did. You're going to present what? So we decided, okay, mechanism of injury. I've been doing trauma for 5 years, and I was an ER nurse for many moons before that. And so I thought, yeah, we can do that. I really actually know what that is. Russ? I think there's... Sorry, I'm computer illiterate.
Just push this button on the left.
Can I just do that one?
Yeah.
Okay. You can't push it very fast. All right, here we go. So, mechanism of injury. So the epidemiology of trauma, basically, trauma is the leading cause of death for ages 1 through 44. There's 140,000 unexpected deaths per year. Automobile-related, it's greater than 40,000, and it's responsible for about 40% of the U.S. healthcare costs. Most common causes are traffic crashes, falls, and violence. So a little bit of basic law of motion. Energy cannot be created or destroyed, but it can change in form or be absorbed. Motion injury is basically caused by the body's absorption of energy. A body in motion remains in motion unless acted upon by an outside force. And by an outside force, we're talking the car, the tree that you hit, when you fall from a building, the ground. So a little bit of history is what makes mechanism so important. And I think as we all know from working in the emergency department or as first responders, that's basically, kind of where we start. So a thorough history, typically it'll identify 90% of injuries. You need to know the incident site, so you know the bad locations. Hey, I just brought so-and-so in from such and such, and a lot of times people will kind of know what happened just by your report. Major factors of tissue injury, what forces were applied. So were they shot? Were they stabbed? Did they fall from 30 feet? Were they in a car crash? And how fast were the vehicles going? Anatomical structures that are potentially involved. So you really need to make sure that they understand when you're giving a report. Sorry. Okay. So you really need to understand that when you're giving a report, people need to know exactly what happened, how it happened, and where on the body the person may be potentially injured. So here's a little scenario, and this hopefully will let you know just how important the story is. So the scenario, a 40-year-old male, he's en route via ambulance to the emergency department. The first responders call in the report, and this is a very brief history because they're in a hurry and they're working very hard. So this is a 40-year-old man. He has a rabbit bite to the left shoulder. Patient is unstable by report, and there's no other history available. Now, does this make sense to anyone? No. Well, let me go. We actually have a video clip. It's quite graphic, And it kind of tells the rest of the story. If I can make it work. There we go. Maybe. Yeah, it does. Is it gonna work? There we go.
There he is! There he is! Where? Where? There! What, behind the rabbit? What, behind the rabbit? It is the rabbit. It is the rabbit. You silly sod! You got us all worked up! You got us all worked up! Ordinary rabbit! Foul, cruel-tempered rodent you ever set eyes on! You! I saw my arm and I was so scared. It's got a mile wide. It's a killer. He'll do you up, mate. Mankeys. I'm warning you. Nibble your bum. He's got seeds sharp. He can leap about. Look at the bones. Go on, boys. Chop his head off. Right. Leader. Coming right up. Look. Jesus Christ! I warned you. I've done it again. I warned you. But did you listen to me? Oh, no, you knew. Oh, it's just a harmless little funny, isn't it? It's always the same. It's always the same. Shut up!
So the reason I showed that is just to show you that you really do need the whole story. So with this scenario, yes, you've got a 40-year-old man. He's coming in. He's got a bunny bite to his shoulder. And as you can see, there's multiple victims. Look at the places where they could have been bitten and look at how severe the injuries were. And you didn't get that from the initial story. So it's very important to give the whole story. The other thing you need to be worried about or concerned about is not to get tunnel vision. There are injuries that look horrible, and people tend to focus just on those. This injury yes, it looks bad, and yes, it needs to be fixed, but no, it's not the one that's going to kill this patient. So you need to make sure you look at the entire patient and not just the injury. Keep the assessment focused. So this injury, this kid comes in and he actually looks relatively well. He's got bruising in certain places, and you need to kind of understand that, the structures that are underlying these bruises could actually be injured, and yes, these could kill him. He could have a liver laceration, he could have a pelvic fracture. So you really need to be focused on what the injuries look like and what really could potentially happen to this patient. So entry into a trauma system, we have certain criteria. Physiologically, a systolic blood pressure of less than 90. These are with findings of hyperperfusion, suspected etiology. So again, you need to put the whole picture together. Respiratory distress, that's a rate of less than 10 or greater than 29. And altered mental status with a GCS of less than 13. Anatomical, so a flail chest of any type, and that's multiple rib fractures. 2 or more long bone fractures, that would be like a humerus or the femur. Penetrating injury to the head, neck, torso, or groin that is associated with significant energy transfer. Partial or full thickness burns to the face or airway. And you're concerned especially about the face because you are concerned about an airway injury. Amputation proximal to the wrist or ankle, and paralysis of any limb associated with a traumatic injury. Mechanism, and here we go. Extrication taking greater than 20 minutes, excuse me, with heavy tools. Death of an occupant in the patient's vehicle. Ejection of the patient from an enclosed vehicle, or falls from greater than 15 feet. And again, it doesn't matter what the patient looks like. They can look just fine, and if they have any of these mechanisms, you really need to get them into the trauma system and assess them fully, because there may be injuries that you're not seeing. Comorbid factors, age of less than 12 or greater than 60, someone who is pregnant that has been involved in a traumatic incident, significant pre-existing medical problems, and extremes of environment, hot or cold, and presence of intoxicants. Your index of suspicion. Any patient can be entered into the trauma system with a significant mechanism of injury, regardless of the findings. So you walk into, or walk onto a scene, and this patient looks just fine, but you look up and you think, gee, they just fell from 20 feet. They need to be entered into the trauma system. You can't just say, oh, you're fine. And you need to document the reason for entry. So mechanism of injury, this is just a slide. Okay. It tells its story. I don't need to even comment. Again here, everybody keep left. Wrong thing to tell 2 cars coming the opposite directions. So motor vehicle crashes. Motor vehicle crash, they can be broken down into 3 separate impacts. So the vehicle impact, that's when the vehicle strikes another structure. That could be another car, a tree. The second impact is the body, and that's the occupant. And again, it's the force in which they're thrown. And that's striking a steering wheel or the windshield. And then the organ impact within the body. And that's, can be the brain, the heart, the liver, spleen, that impact onto another structure. The relationship of bent metal to patient injury. There's an unpublished study of greater than 100 motor vehicle crashes. Pictures taken of each car. They compared the damage to the patient, and there's a negative correlation. So the picture doesn't always fit. However, there's a positive correlation with damage to the interior of the car. And the reason for that is think about what happens if someone's unrestrained or whatever, and you see a bent steering wheel, or you see that the windshield has been scarred by someone hitting their head, then you can kind of deduce from that there is an injury to the patient. Of the vehicle, do they take the pictures inside as well?
Yeah, they take
Yeah.
a little bit.
Well, and again, then they have an idea, because people out on the scene, they can see what happens. They know how serious it is, and it's hard to relay, sometimes just how damaged the vehicle is and how injured the patient might be. So, again, this is the inside of a car, and as you can see, you can only imagine, how injured this patient might be. The windshield is scarred. The dashboard is completely up in the front seat. The steering column is bent. Frontal impacts, so this is like a head-on. Vehicle impact, extent of front-end damage you need to assess. So when people come into the emergency department and we ask for a report as a trauma team, that they often will say, this is a such and such person, these are their vital signs, such and such, and this is what we found at the scene. It's a much different story if they say, oh, it was a car going approximately 2 miles an hour and ran into the bumper of a car in front of it that was stopped, versus this is a vehicle that was going 100 miles an hour, hit another vehicle going 100 miles an hour. The injury patterns are completely different, and what you look for may be completely different. Again, body impact, we always look for windshield damage, and windshield damage typically will tell you, possibly will tell you that they have a head injury, that they've kind of flown up over the steering wheel and hit their head on the windshield. Steering wheel damage, you look for chest injuries. Dashboard damage, if they've gotten pushed into the dashboard, typically it's a knee, femur, or pelvic injury. And then organ impact. Obvious soft tissue injury, lacerations, abrasions, bruisings, contusions, or fractures to the head, neck, chest, and abdomen. And these are all what can be seen in front impact crashes. And that's kind of a nasty one. Indications of an unrestrained victim. So that's very important too. Always, 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 if you can, if you know, let the people you're bringing the patient to know whether the patient was restrained or unrestrained. It makes a difference in what you look for. Again, windshield damage, head injury, scalp, face, neck injury. You get hyperextension or flexion of the C-spine. Steering wheel damage, fractured sternum, and we all know what lies behind the sternum. That's your heart, so you can have cardiovascular injury, larynx or trachea injury, soft tissue injuries to the neck. You can get a pneumothorax, hemothorax, flail chest, and intra-abdominal injuries. Lateral impact, so to the side, and it's to the side. It's nice to know which side of the vehicle was struck. Body impact, you get the intrusion of the door, the armrest, window, other parts of the car into the victim's space. Organ impact. Again, head injury, people hit their head on the window, the side window. C-spine injury, thoracic and lumbar spine injuries, chest and abdominal injuries. You can get upper arm, shoulder, and clavicle injuries on the side of the impact. Pelvic, hip, or femur injuries on the side of the impact too, and that's from the intrusion of that side of the car into the victim. Right, and they've come out with the airbags that are on the side, but that may protect your head, but it doesn't protect everything else. So. Right. So lateral impact. Rear impact collision. Most common type of rear end collision is when a stationary car is hit from behind by another car. And again, speed is a big deal, and also the types of vehicles is helpful to know. Injuries occur as the torso and seat shoot forward. If the headrest is too low, the neck will end up hyperextended over the top of the headrest. So you get strains, torn ligaments, and serious cervical injuries. And we see these a lot. Even in low-speed crashes, people can have a C-spine injury. Again. Rollover collisions. Occupant can be tossed around and injured from all directions, so you kind of get frontal, lateral, and rear end collision injury patterns. They're difficult to predict because you don't know how many times, oftentimes you don't know how many times they rolled, you don't know where the patient ended up. They can include all types of impacts and a greater chance of occupant being ejected from the vehicle. Rollover. Ejection from the vehicle. If you're ejected from the vehicle, so this is kind of the take-home message, you should wear a seatbelt. You're 25 times more likely to be killed. So these people that say, well, thank God I knew this friend who didn't wear their seatbelt, and that's the only reason that they were able to escape the burning car. Well, that happens very rarely. If you're ejected from the vehicle, you're 25 times more likely to be killed. Injuries that result after the second impact when the body hits the ground are often more severe than the initial impact, and that's because you're kind of a projectile. Distance, and again, it all comes down to something has to stop you, and typically it's the ground or a tree or something else. Distance between the victim and the vehicle usually indicate how fast the car was traveling, and therefore how much energy was absorbed by the patient. 1 out of 13 ejected victims sustain spinal cord injuries. And we just recently had an incident where all 3 people were ejected from the vehicle, and I believe at least 2 out of the 3 had severe, significant spinal cord injuries. So restraints, so seat belts. Again, I absolutely applaud people that wear them, but they need to be worn correctly, and sometimes they're uncomfortable. But again, they should be worn correctly, positioned across the pelvis and above the femur, and they should be pulled tight enough to remain in this position. They protect the occupants from impacting with the side of the vehicle and prevent the occupants from being ejected. Restraints, again, if they're worn improperly, they can be a source of trauma. So again, the newer cars don't have just the lap belts, but back in my day, they did. And on occasion, you should still see the 72, I can't even remember the names of cars. But anyway, with just the lap belt. Common compression, or you just see people that are wearing them incorrectly. So compression injuries to abdominal organs if only the lap belt is used. Burst injuries to the small intestine and colon, the same. Rupture of the diaphragm due to increased abdominal pressure. And then head, face, and neck trauma if the lap belt is worn along. Neck injuries if the shoulder belt is worn along. And so these are just some seatbelt signs. This is actually, these were people who actually wore them properly. If you see the initial, this gentleman up here, you can actually see the lap belt as well as the shoulder harness sign. Right here, just the shoulder. And then down at the very bottom, you can see the lap belt. And what this is showing you is if people come in with this type of a sign, you need to be aware that the underlying structures can be damaged. So with regards to the, with regards to if you see one around the neck, you worry about vessel injury to the neck, tracheal injury, esophageal injury. If you see going across the chest, you worry about cardiac contusion, pneumothorax, hemothorax. And if you see the lap belt, you worry about the underlying structures like pelvic injuries, bladder injuries, and internal organ injuries. Motorcycle collisions, it's spring or it's almost spring, and so we'll all be seeing more of these. 75% of motorcycle deaths are due to severe head trauma. And I think people need to know that helmets help prevent head trauma. You should wear one, but they don't always, you can still have head trauma with a helmet on, and they offer absolutely no protection against spinal cord injury. Injuries are similar to victims ejected from the vehicle. That kind of goes without saying. Again, you become a projectile and something has to stop you. And we typically see injuries of the head, neck, and multiple extremity trauma. Auto versus pedestrian collisions. So questions that need to be asked and answered and relate to the people that you're bringing your patient to are the height of the bumper versus the height of the person that was struck. It creates a whole different injury pattern. Adult versus child, and basically for the same reason. Side or frontal impact, and the shape of the vehicle front. And again, all this is for injury patterns. Multi-system trauma should be assumed even if they are asymptomatic. So if you get a patient or you come upon a patient who was involved in an auto-pedestrian collision, you need to first ask all of these questions because your injury patterns will be different. And second, even if they say, I am absolutely fine, assume that they are injured and make sure that they are evaluated completely. So falls. So factors that you need to be aware of in falls, you need to know what the distance is. You need to know the body part that impacts first. Typically with a small child, their heads are bigger. They're going to impact with their head first, or with an old person like myself, they're going to trip and sometimes impact their head first. Objects struck during the descent, so if they're falling downstairs, if they've fallen off a building and they've hit something on the way down, and the type of landing surface. So not a big surprise that your injuries are going to be less severe if you land on a pillow versus concrete. Falls are considered severe if greater than 3 times the height of the victim. So for someone like me, that's not very high, but for someone who's tall, it's a little easier. But so just remember that you have, a small child who falls off a bunk bed. I mean, that can be actually a severe injury. You have, an adult who falls from the same distance, maybe not so much. You need to just check, how did you fall? Head first, you find that it's a compression injury. You can get skull fractures, brain injuries, and spinal cord injuries. Deceleration, so as you fall, you stop fast, the organs in your body continue to move, and they can have some tearing and injury, and typically we see it in the aorta, the kidney, and then any other internal organ that's tethered by tissue. Feet first falls, so some people choose to jump, like this gentleman here. Other people, accidentally fall. But if you land feet first, this looks like it's going to be a soft landing because there's snow, but you don't know what's underneath the snow or how deep the snow is. And so if you land feet first on a hard surface, you impact onto your calcaneus. You can get foot calcaneal fractures, continued motion of the torso. You can get ankle, knee, femur, pelvis. Typically we see spinal compression fractures and injuries of the torso. So the energy kind of goes all the way up your body when you land like this. So injury patterns with adults. We see lower extremity fractures, hip or pelvic fractures, lumbar or sacral spinal fractures, and wrist fractures. And wrist fractures because you try and stop the fall. In children, you see the associated head injury, and that's because their head is the heaviest part of their body and typically impacts first. Penetrating injuries, so stab wounds. So severity of the wound depends on location. And again, with stab wounds specifically, don't be lulled into a sense of calm because it looks innocuous. You need to know a couple of things. Stab wounds that have entered the upper abdomen may have reached the organs in the thoracic cavity. So it depends on who stabs you and what the trajectory is. Stab wounds that have entered the chest wall below the fourth intercostal space may have injured abdominal organs. So they're interconnected. So you need to know the blade length and you need to know the angle of penetration, and just based on what you know of anatomy, kind of understand where things are in the body, and then you can have an idea of how severe and these injuries might be. They're low-velocity fixed devices, and they're usually hand-driven weapons. You could be stabbed with a knife, a fork, an ice pick, a machete. I've seen it. Victims can be impaled on objects, and if you follow the trajectory of the implement, you usually find the injuries. So you really need to know which way. I mean, all stab wounds, for the most part, need to come to the emergency department. They need to be evaluated. Patient is brought in with a single knife wound to the leg. The EMS report is sketchy and stating that the patient is shocky and lost a lot of blood. So things you need to know for incidents like this. Where is that person stabbed? What is the treatment? And what stuff do you need to do to prepare? And that's why it's so important to give a full history to the emergency department when you bring a patient in. If you have it, keep the weapon away from the patient or whatever, but bring it with you so that they know exactly what they're dealing with and what to look for. Firearm injuries, penetrating injuries. The severity of the injury affected by the following factors. Type of weapon. So again, history. Was it low velocity? If it was, they're less destructive than a high velocity weapon. And if you're like me, I know nothing about guns but this. So if somebody says, it's a low velocity weapon, if you have that information available to you, that really helps us to evaluate the patient when they get to the emergency department. Caliber or size of the bullet. A larger bullet causes more resistance and therefore a larger area of damage. Distance from which the weapon was fired. Increased distance will increase or decrease velocity. And bullet deformity. Hollow point and soft nose bullets cause larger damaged area. So all of that information, even though you may not think it's, it's not as important as you think it might be, you might want to just say, oh, they were shot. If you can get this information prior to coming to the emergency room, it's very helpful. And big entrance, right. So again, it's similar with stabbing injuries. Don't be lulled into a sense of calmness just because they have a teeny hole. You don't know what's behind that, and you don't know where the exit wound is. And like you say, sometimes the exit wound looks worse than the entrance wound. You need to know the trajectory of the bullet. So the bullets can tumble and oscillate vertically and horizontally, resulting in larger surface area meeting the surface of the body. And then I'm talking inside the body. So you don't know what damage has been done as that bullet has gone through. Wounds from firearms. Entrance wound can be round or oval. Shots from close range may have burns on the skin. An exit wound, if present, and sometimes there won't be an exit wound. Sometimes the bullet is lodged inside the body somewhere. If present, though, it is possibly larger and may be linear or stellate in appearance. Not all entrance wounds will have an exit. And internal wounds. The damage to the tissue is in the direct path of the bullet will cause a permanent cavity. Tissue on the other side of the pathway will also be injured. 85 to 95% of wounds caused by firearms will require surgical intervention. And oftentimes that's not just to fix something, that's to look inside and find out what has been damaged. And only 30% of knife wounds will require exploration. Blast injuries. So blast injuries can come from explosions, from laboratories, shipyards, chemical plants, tank trucks, refineries, fireworks, silos, and LP gas tanks. Understand that it's important for who's ever bringing a patient in who has the information to relay where the blast occurred because they can have associated injuries depending on where they were when this happened. The blast effect is broken down into 3 phases. Each phase has a different energy pattern. The primary phase, it's caused from pressure from the initial blast, and it affected areas, gas-containing organs. So injury include pulmonary bleeding, and again, you may have absolutely no outward site of injury. But a pneumothorax, air emboli, perforation of the GI tract, and burns. But again, with something like this, it's just the initial blast. You've been thrown forward or backward, and you have no outward sign of injury, and you could have internal injuries, significant internal injuries. The secondary phase, it's by flying debris, so the door flies off. It actually hits you. You can have the affected area or the body surface and the skeletal system. You can have lacerations, fractures, and again, burns. And the tertiary phase, or the third phase, victim is thrown against an object, affected area, impact, or referred energy, and the injuries can be similar to those sustained in vehicle ejection, which include internal injuries, fractures of the long bones, really everything, head injuries. So, questions I would always tell people to ask when you're trying to fix something or when you're trying to make things better, which the trauma system can always be made better, and everyone has something to bring. Or why are we doing this? What problems are we solving? Is this actually useful? Which I think it is. Are we adding value? Which I think if you're always trying to make something better, yes. Will this change behavior? Possibly. Is there an easier way? We hope so. What's the opportunity cost? And is it really worth it? So I think that if we all strive to become better at sharing information with each other as far as mechanism, we actually treat our patients better. Any questions?
To give you quick
Yeah.
stab wounds, if we have time in the hospital and they have a sterile, do you want us to ever
I don't know if I mean I don't know if you mean when you're picking a patient up. Hopefully they've done that, but I don't think the utility of you guys doing it. Probably not so much. If you can get the information to us as to, this was because, like Russ was telling me earlier, females tend to stab from this direction, and males kind of up. And so if you kind of even know, who the assailant was, or was it self-inflicted, and what type of a weapon, and what you think the trajectory. I mean, I think that's probably what we really need because we have to do that anyway. I guess you really wouldn't hurt anything if you did, so it wouldn't hurt, I don't think. And I would imagine that at the outside hospital, you would think they had already done that. But yeah,
I don't know. If we're ever bored, I was just curious if there's.
yeah, I probably not. I mean, I think if you get the story, that's probably more helpful to us as to what to look for. Yes, Jen.
Oftentimes, when you're getting a report in the public and having these people go to sleep that will provide all the information that we're required.
Well, I think probably the best thing to do would be to practice and get it down to, go by system and just get everything included in a very succinct way and leave out all the other qualifiers that you don't need. So say it's a stabbing. This is a 40-year-old male who was stabbed by his girlfriend. Only one entrance wound was found. It was in the chest. The knife was, a kitchen knife that was 3 inches long. Really, that's all you need. And there were nothing else found at the scene. Say that, it's a motor vehicle crash. This is a 30-year-old male who's involved in a head-on motor vehicle crash. Mid-size vehicles, involved 100 miles an hour, both. You can keep it fairly succinct, and you just need to touch on each of the, each little topic. So I wouldn't leave anything out because that's all important, and I know it's crazy in the trauma bay. I think what you want to do is just make sure you're not including information that's not useful, like allergies, and initially.
Sometimes they're not interested in the social history or something like
Right,
that.
right.
It's rolled 15 times or something like that. That's not.
Right, I think they want initially is the patient status and then mechanism of injury. Yep. So you just do the basics, and then they can ask for anything else they want based on the initial information that you're given. Yep. And I think mechanism is fairly important because that kind of guides them to where the injuries might be and what they're looking for. Anything else? All right. Have a good day.
Great, thank you.
Oh, you're welcome.